are very important to understand as far as reliability and validity is concerned. Now, any idea before that I tell you what is reliability and validity? Anything that you know about it beforehand? I know Ali want to share something
Ma'am,
because in very beginning, early sessions, Ali told us, or Ali tried to tell us something about it. I said, Ali, hold on, we definitely talk about that one day. So today is the time, Ali. You can come up with your understanding of validity and reliability. And two by two
ma'am,
table, I remember.
ma'am, yes, ma'am. Whenever we conduct a test, we also get the 2 by 2 table in which we get the two positive and the two negative results. Ma'am, that gives us an insight about the sensitivity and the specificity of the test.
Oh,
Uh,
okay.
so sensitivity of a test and the specificity of a test is basically the two different terminology. Some tests are sensitive and some are specific. So this is actually the domain of this chapter, I guess, according to my point of view. I might be wrong.
Okay, no, you are not wrong. Most of the points they are there, although a little scattered. We'll try to align them and put them in a way that everyone will be able to understand. Now, we all study this validity and reliability. Ali is so right that in our clinical practice, most of us we are doctors, so we know that in our clinical practice, whenever we have to diagnose anything, so we don't really jump onto the diagnosis in a single go. And at times we have certain tests which are lesser sensitive or which are lesser specific, and there are certain tests which are considered as diagnostic or they are considered as gold standard. I'm sure you must have heard this term of gold standard कि जी ये टेस्ट इस डिजीज की डायग्नोसिस के लिए और आइडेंटिफिकेशन के लिए दिस इज अ गोल्ड स्टैंडर्ड टेस्ट राइट simplest example is that, say, for example, for CA breast, generally mammography is taken as a screening test, right? Or self breast examination is considered as a screening test. And the gold standard or the diagnostic test for this is considered as a true cut biopsy, right? What we do that whenever a surgeon needs to decide that whether I should go for surgical treatment or not, what we do, I'm getting okay, there is a lump in the breast, or that patient can appreciate, or a doctor can appreciate. But to be sure about the nature of that lump, that whether it is carcinogenic, whether it is benign, it is malignant, what we do, we just do true cut biopsy. We take a little chunk of the tissue and then we send it for the examination and then we decide on that. So that is basically considered as your gold standard or it's considered as a diagnostic. So when we talk about this, this means that we are having two different types of, test. One is known as screening test and others are known as gold standard test, right? Now, unfortunately, it's not given in that much detail in the book, so I'm going to share it with you through this whiteboard. That what it is. Screening test, there are differences. So we'll be definitely talking about the differences between the screening test and the diagnostic test. But before that, we should be knowing that what screening is. What is screening? Any idea?
मैम स्क्रीनिंग इनिशियल टेस्ट होता है मैम जिसकी कोई इतनी कोई डायग्नोस्टिक वैल्यू नहीं होती बट इट्स जस्ट गिव एन इनिशियल असेसमेंट ऑफ द प्रेजेंस और एब्सेंस ऑफ अ डिजीज
Yeah, it gives us an initial assessment, or it helps us in identifying whom. Here comes the role of that iceberg phenomena of the disease.
High risk, risk, ma'am,
Ma'am,
of developing
subclinical cases, carriers.
subclinical cases, ma'am, the
Very
carriers
good.
or inapparent cases.
Very good. The carriers, inapparent cases, at times individuals who are in the preclinical phase, subclinical individuals, or undiagnosed. There are diseases, and generally, whenever we use this term screening, is basically done for chronic diseases or it is done for non communicable diseases. Why? because these diseases, they take years to develop. Why do we call them as chronic diseases? Because they manifest themselves in the form of signs and symptoms once they've caused sufficient damage to the body. They take years to develop. So that is why we just make use of these screening tests to identify the hidden chunk of the disease. This submerged portion of the iceberg represents the hidden chunk of the disease. This is hidden. Which particular proportion we make use to identify the amount of illness in the disease is this one, the tip of the iceberg. The tip of the iceberg, we know that the tip is floating and it's visible, but there is a huge submerged portion of the iceberg that is hidden from the naked eye. So generally, this model is applicable to the illness that we can always explain. What is happening, that the amount of illness or the prevalence of illness that is visible to us is basically those individuals who have been diagnosed by the physicians or by the clinicians once they visit some healthcare facility on their request because they were suffering from signs and symptoms. And we intend to relate that this is the amount of illness in the community. But in fact, this is not. There is a huge number that is still not visible to us. So, to identify that hidden amount of disease in the community, we make use of screening. Screening, this is the search. What is screening? So, screening is basically the search for recognizing the unrecognized or undiagnosed illness in the community by means of rapidly applying tests on apparently healthy population. This is again a catch. Screening is done on apparently they are healthy. They might not be knowing that they are at the borderline of diabetes or they are at the borderline of hypertension, right? So that is why we just make use of screening tests to identify the amount of illness in the community that otherwise might not be. Sometimes individuals, they don't really know that they are suffering from some disease like diabetes and hypertension, and just by chance they visit hospital because of some other illness, and just on their routine checkup they get to know. Or if probably they get some wound and that wound is not really healing, so that they just got their routine investigation done and they got to know, okay, Chaji, we were suffering from diabetes, or they were suffering from headache, or they were suffering from some sort of palpitations and things like that, and they just got their examination done, so they got to know that they are suffering from hypertension, right? So there might be some mole, or there might be some nodule in the body, and if you just go there, go in the hospital and visit hospital for some other reason, and on general physical examination, a physician might even pick that nodule and might ask you to get its FNAC done, fine needle aspiration. And then you might be diagnosed, God forbid, anybody might be diagnosed with some cancerous lesions, right? So that is how, but in the beginning, we always take a certain start with the screening test. So that's why screening test and the diagnostic test, they are generally different. Now, whenever we have to approach any community for the screening test, we don't really go ahead with the extensive invasive diagnostic test. We take a subtle start. We go with non invasive, less expensive, less embarrassing, more acceptable, more accessible, and less expensive tests. And they are generally screening tests. And they are the ones which are done on apparently healthy population. They are healthy, and we intend to apply on masses, right? Apparently, we apply these tests on healthy population, right? And here, diagnostic, on whom we apply diagnostic test?
When the clinically is
Ma'am,
clinically diagnosed,
On a clinically
who
manifested.
clinically manifest.
Yes. Those who are suffering with a clinical illness, those who are coming up with some signs and symptoms.
or with the positive screening test.
Or at times, absolutely. At times, what happens, that screening test comes out to be positive, then we don't really start our treatment there and then. What do? we subject them to diagnostic tests. We just
Ma'am,
ask them to get it done. We just ask them to get these tests done. So once they come out to be positive, then we decide that okay, which particular treatment strategy we should ask them to adopt if they are in the borderline. So then like in diabetes and hypertension. So we don't really straight away put them on medications, or we don't really straight away put them or label them as hypertensives or diabetics. What we do, we monitor their blood pressure in sitting, lying, 24 hours. And then we see that okay, whether there is fluctuations in the blood pressure or not. And then we just take a start with their lifestyle modifications. If they are obese, we ask them to cut down their calories, to reduce their body weight, increase their exercise, walk, and all that. But even then, if somebody is unable to bring his or her blood pressure in the normal ranges, then we put them onto the medication, because we know that they are lifetime diseases. So till the time a person is alive, a person is going to stay with medications and stay with that particular disease. Okay, so it is done on apparently healthy people and it is done on diseased individuals. Okay, here the initiative is coming up with some researcher,
Ma'am,
you know,
epidemiologists.
yeah, epidemiologist or some agency or some funding agency or donor might be behind that, like UNICEF, UNDP, WHO might be interested in knowing that what is the burden of illness shared by lower middle income countries, or by underdeveloped countries as far as these non-communicable diseases are concerned. So they might ask you to do screening, so mass screening, and so we'll definitely talk about the types of screening also. But here the initiative is coming from the clinician, right? The doctor or physician is going to say that okay, you need to undertake these tests. So apart from that, they are less diagnostic. They are less diagnostic. They are more diagnostic. They are. I have limited space, so I'm just telling you. So you can always write them up with you, because they are not written in this way in Beyond Borders. So we can always say that they are never used as a basis for treatment. Screening test is not used as a basis for treatment, but diagnostic test is used as a basis for treatment, right? We never put anybody on medication if screening test comes out to be positive, because we need to subject these individuals to a higher or to a more sophisticated test before putting that individual onto medication. Okay, but if a diagnostic test comes out to be positive, then we are going to use that as a basis for our treatment, for initiation of the treatment, right? So it is less expensive, it is more expensive. It is less invasive. It is more invasive. Diagnostic tests, they are generally more invasive. Okay. So it is done on groups of individuals. Screening test is generally done on groups of individuals. But diagnostic tests, they are generally done onto patients, onto individuals. Okay. Okay, so we need to be very carefully choosing that which particular screen test I should be choosing. Okay, looking at the we always try to weigh and balance our screening test with the gold standard or the diagnostic test. That how much our screening test is good enough, how much is the picking ability of our screening test, how much positive individuals my screening test will be able to identify correctly, and how much result is going to be given false by my screening test. How much test results by my screening test they are reliable or valid. So this reliability and validity will talk in detail about our screening test. But before that, let me just tell you about the types of screening tests. They are very important. Okay. Now, what are the types of screening tests? Anyone? Any one of you? There is one screening test that is known as mass screening, right? And then there is screening that is known as high risk screening, high risk screening strategy, right?
Ma'am, in preventive, we also study two sort of strategies.
Absolutely. Yeah, in our initial sessions, absolutely, Mayur.
Yes.
High risk. We also call it as selective screening also. High risk or selective. Because at times, you never know about your examiner that they might ask you very basic things. So at that time, we shouldn't be just, you know, uh, wasting our numbers because the basic concepts should be clear. Selective screening strategy, because this mass screening is also known as population screening. And there is one screening that is known as multiphasic screening. It's not given, I'm telling you again and again in this way in your book. Multiphasic screening, right? So it's better if you note down with you. Although I'll be sharing my videos with you, so it's all going to be saved here also. Okay, coming to our first strategy that is known as mass screening or population screening. Who is going to explain by reading this term mass screening what idea comes in our mind?
Ma'am, generally entire
Entire
population is screened
Population,
Very
yeah,
good.
entire population.
without any
selected groups or
select,
individuals.
yeah,
Very good, very good. Without
without any
identifying,
discrimination.
without any discrimination or without any prior selection of high risk group or categorizing individuals into high risk category or the low risk category. So, what is our agenda? Say, for example, if you have to do screening for diabetes, say, for example, you just subject everyone to screening test in Rawalpindi district if you want to look into the prevalence of diabetes in Rawalpindi district, or say, for example, in Pakistan. So, everyone is subjected to screening test. So that is going to be labeled as mass screening or population screening. Now, what could be the disadvantage of having population-wide screening or mass screening?
Ma'am, it's very expensive.
It's very expensive. It is going to be costly, or it's
Costly,
going to be
time consuming, ma'am.
very good. Lot of manpower is required. Lot of resources required. Obviously, if the catchment population is so big, so you need to have a big human resource so that they can get an access to each and every individual in the population. You need to have lot of logistics. You need to have lot of kits available for you. But the yield is not going to be maximum, right? The amount of disease that we'll be able to identify after doing mass screening or population screening might not be that much, might not be that big if you compare it with your expenditure that you are spending, right? Now, in comparison to this mass screening, there is high risk screening or there is selective screening. If they ever ask you that which screening strategy is considered as the best screening strategy, that you will label high risk screening as the best screening strategy, okay? Straight away. Why this high risk screening is considered as the best screening strategy?
Ma'am,
Because
targeted
only
OCS,
those are screened
cost effective
family
OCS.
history positive. Yield maximum.
It is
Ma'am,
the
maximum
very
output.
good maximum amount or the maximum yield we can identify from high risk individuals. Because obviously, if they are running some particular test, so we are going to get maximum diseased individuals by screening that particular population. So, for example, if you just
Ma'am, actually, we are
Gee.
talking about the true positives here.
Yes, yes, absolutely. Truly diseased or true positives. I'll be coming to those terms also. Diseased individual. So when I say disease, this means that those who are really diseased, not the false positives, not the false negatives, right? I'm talking about the ability to identify diseased individuals, okay? Now, say, for example, if we want to identify STIs, so rather than examining every individual for sexually transmitted infections, we are going to target high risk population. Like we might be interested in looking among commercial sex workers, we might be interested in looking in homosexuals, we might be identifying transgenders, we might be interested in looking among truck drivers also, because they are also high risk group for STI, right?
Like thalassemia.
Yes, for thalassemia, absolutely. So, similarly, now if you are interested in looking for some cancer, so we need to identify high risk population rather than subjecting each and every individual to all those who are running certain risk factors, like those who have a positive cancer history in the family, right? Those who have a positive, other risk factors, like if they have certain risk factors, like they are, they are obese, or they are smokers, or they are indulge in other certain, high risk habits, they have risky lifestyle behaviors. So we might be interested in looking for those particular diseases among. Now we don't really screen everyone for HIV. We don't really subject everyone to Western blot to identify that, or for the PCR, that whether somebody is having HIV or not. We target high risk population to get the maximum yield. By maximum yield, I mean the amount of maximum disease that we can identify. The yield is the amount of the disease that we can recognize with the help of screening tests, which were previously unrecognized, right? So that is what is basically the purpose behind high risk strategy or selective screening strategy. Okay, that's why selective screening or high risk the screening strategy is considered as the best screening strategy for identifying unrecognized disease. Then coming up to multiphasic, or we also call it as sequential or simultaneous. It has got two different, types. This multiphasic, sequential screening or simultaneous.
Go to Papa.
Now, multiphasic, as the term says, multiphasic. Now, here we are applying more than one screening test. Say, for example, that we did, a random blood sugar testing on our individuals, and then we just subject those individuals for their, 2 hours postprandial. OGTT, oral glucose tolerance test. Now, this means that we subjected them to two different screening tests. Okay, so that is known as multiphasic screening strategy. And ideally, multiphasic screening strategy is the best one. But again, same issue, it is very, very costly and expensive, and yet expertise are required for them. Once we say simultaneous, by simultaneous, as the term says simultaneous, this means that simultaneously we are subjecting our population to two different tests together, all together, right? By sequential, we mean that we subject all those individuals to one screening test, and then all those who come out to be positive on that particular screening test, we then subject them to another screening test to see that how many of them they are really positive, right? So, but in simultaneously, what is happening that all of them are subjected to one, and simultaneously all of them are then subjected to another screening test, and then we just calculate that it's a lengthy procedure, and we just then calculate. Not we don't really just calculate sensitivity specificity that otherwise we calculate in other screening tests. Then we calculate net sensitivities and net specificity. We'll talk about this in detail. So need not to worry and need not to get scared right now that what are these terms. Right now, what are you supposed to remember? That we have three different types of screening strategies. One is mass screening, other is high risk, and the third one is multiple. But if somebody asks you, but if this question comes in exam, that which strategy would you choose for screening your population, or what do you think is the best, you will choose high risk screening, because high risk screening gives you the maximum yield, right? So this we from this, the gist is that we need to identify this. Okay. Now, and apart from that, this we are going to cover in detail, sequential, simultaneous, and all that. Okay. Now, having said this, now there is one another very important thing. Why I'm telling you all on whiteboard, because it's not given in this form in your book. Otherwise, I would have made a PowerPoint from Leon Goddess for this. There is one criteria that is known as Wilson's criteria. And this is after that scientist who identified that. This is Wilson's criteria for screening disease. there is a criteria that which particular disease we should be screening out and which particular criteria we should be having for an ideal screening test, right? So Wilson's criteria is basically criteria for disease to be screened, right? For the disease, that which diseases they need, because we don't really start screening out each and every disease. Okay, which disease needs to be screened and which screening test, there is a criteria for our screening test also, that what is a good screening test, which particular screening test we should make use of, right? Criteria for screening test. Which screening test is going to be labeled as a good screening test, right? Okay. Now, talking about Wilson's criteria first for the disease, and then definitely I'll talk about the criteria for screening test also. Okay. This is the criteria for screening test. Okay. Okay. Now, Wilson's criteria. Now, what do you think? Which diseases they should be screened, or we should screen? We should start screening each and every disease.
मैम कोई prevalent health issue हो, कोई important disease हो.
Very good. The foremost, most important thing, that it should be an important public health issue. It should have it's an important public health disease. It's prevalent also, right? And it is causing what? It is causing lot of morbidity and burden. Number one, the topmost priority, that it should have been an important public health issue. Very good. What else?